Am I on now?
Yeah.
Yeah, that works. A little loud, actually. Let's move it.
Is it too loud?
We might
Testing,
be
testing,
we might
testing.
be getting dual things,
All right.
but that's okay. Hopefully this is loud enough. How's that? It'll do. I'll be off in a minute anyway.
Hey, Karen, nice to see you.
So is that clock correct? So we get started. It's 11:30. Welcome, everybody. My name is Aaron Cohn. I'm a professor in the Department of Medical Informatics and Clinical Epidemiology. I know many of you, but not all of you, so welcome. This is our regular Thursday conference. Some Thursday conferences we designate as an IDL conference. My mic is echoing a little bit. Which the IDL is the Informatics Discovery Lab, which is sort of an outreach collaboration initiative within the department, and we bring in luminaries from various industry positions to educate us on what's going on in the real world of informatics. So today we have one of those luminaries, Dr. Richard Gibson, who is a well-known colleague and friend of the department. Before I get into the bio, I'm just going to say a couple of things. I guess this is talk is available for CME credit, and anybody who needs to get CME credit, please email Lynn Schwabe, and she will give you the details. I think you have to take some kind of online test, and she'll do that. Also, we are streaming and recording, so if you have any questions or comments during the Q&A period, please press the little button on the black box in front of you so the light goes on so it gets recorded and streamed. Okay. Anything else logistical I need to say that I forgot? I don't think so. Okay, so Dr. Richard Gibson is our guest today. Dr. Richard Gibson, MD, PhD, is currently the Executive Director of the Health Record Banking Alliance, and he's going to be talking about that today, which is a nonprofit organization founded in 2006 to promote consumer-centered, consumer-controlled, comprehensive lifetime medical records. Dr. Gibson comes to us from Health Record Banking Alliance. Previous to that, he was in a position at Gartner, Inc., where he was the research director. And previously, he's held roles as Chief Healthcare Intelligence Officer at Providence Health and Services, Chief Information Officer at Legacy Health, and Chief Medical Officer at Providence Health Systems for the Oregon region. He's an affiliate assistant professor in the Department of Medical Informatics and Clinical Epidemiology at OHSU. His educational background includes a Bachelor of Science from Stanford, an MD from Case Western Reserve, a PhD in Medical Informatics from the University of Utah, a fellowship at Intermountain Healthcare in Salt Lake City, and an MBA from the Wharton School. He's also, if that wasn't enough, a retired family physician and emergency physician. And I had to read all this because there's no way I could remember all that stuff. So today, Dr. Gibson is going to talk to us about health record banks and how complete data can lead to a better patient care. And I am very interested to see what he's up to these days. And with that, I'll say
thank you, Aaron.
thank you. Thank you for joining us.
So I was scheduled on December 9th, Thursday, to give you a talk on population health management. Really good talk, but I got snowed out then. And then last night I'm thinking, oh, maybe Groundhog Day all over again for this talk. But we're good, and we'll get you out in time to avoid Snowmageddon here in Portland. So no disclosures to make to the audience. And in 1984, I finished my family medicine residency in Spokane. And I owed the National Health Service a couple of years because they paid for a couple of years of my medical school. And so I moved to Forks, Washington. And when I came out to Forks, which is about 5 hours north of here, I was starting a new private family practice there, and one of the doctors was retiring, and so I met him on Main Street where his office was. And he says, well, I have a patient referred to you. I said, oh, yeah? And he says, yeah, it's a young woman who's pregnant. I said, happy to see her. Could I get her records? And so he walks over to his desk and brings back a 5x8 card. And this is just a facsimile, so this is not real patient data. And on the front, it had her birth date, her own birth date, and her birth weight, and then a set of visits all on one line. And then you flipped it over, and again, more visits through her adolescent years, and then positive pregnancy test referred to Dr. Gibson, 1984. Wouldn't you love to go back to those days? I think it's ironic that I've spent most of my career dealing with electronic health records, and now I would not say that electronic health records are in the beloved state that such a card was for some doctors back in 1984. But I do think that there's hope to get back to that easier state where the electronic record is not the thing in front of you in the exam room, but supports your care, and I think that health record banks are part of that. So what we'll talk about today is the general setting for why we're using data in healthcare, all known to you. We'll talk about, I'll review current status of health information exchanges lightly, just to provide context for health record banks. We'll go into health record banks. We'll talk about a proposed business model. We'll talk about blockchain, just a slide on blockchain because it gets asked so often, and then we'll wrap up. So that the challenge we have with health records is that if you're in the inpatient setting, like an OHSU, the patient has a complete record and not a challenge there, and you can see everything that's happened to them at OHSU. And of course, with Care Everywhere, you can see everything that's happened in an EPIC facility across the country. Again, at OHSU, outpatient, you have the same issue, but for most of the care in America, especially in the ambulatory environment, doctors are practicing with only a part of the records that the patients have accumulated over their lifetime. And so the problem is that we get under-treatment, over-treatment, and treatment with errors. So a SureScript survey showed that 55% of care was missing a complete history, and that 49% of the time patients said that their doctor didn't even know what prescriptions they were on. Now that wouldn't apply to OHSU, but we have a problem bigger than the challenge at OHSU. So the case we're making is that we need comprehensive care at the time of care in order to give good care, to do quality, to do policy making, and to understand what we're doing for our patients. That means that care has to be electronic to begin with, so doctors are already on electronic health records, so that's good. And the challenge is now we have scattered information over each electronic health record across the nation about how to get that information from those scattered HIE spots to the place where the patient happens to be right now. And oh, by the way, we also have dental records to do, and we have home care and other kinds of interactions that people have with providers that need to be brought in as well. We already have digital health care, we have common standards, and we need to find a place to pull it all together. One of the challenges, no mystery to you all, is that we need care. We need electronic health records for care at the point of care where they need to be immediate and need to have a rapid response time. And we also need retrospective analysis of care, again, for policy making, for quality analysis, for population health management, for understanding our outcomes and what works best. Now, that requires that you get all the records together, but it doesn't need immediate response time, and there even can be a delay, and we'll talk about that. Why are we where we are? Well, of course, again, no mystery to you all, there's been a medical explosion in terms of data and specialties, which means any given problem requires you to see more than one provider so that you have scattered records. No individual provider tends to have all their records unless you've gotten all your care at a given facility. So there's an opportunity to manage records better. We know that we need to engage patients in population health if we're going to get the best outcomes. They need to be motivated to take care of themselves and be given the tools to do that. And smartphones will play into this. So $564 million of the federal money spent starting 2010 to build state health information exchanges. And HHS weighed in 2013, said more will be needed. And many of the HIEs have already failed, but some are working, and we'll review some of those. So the challenges to health information exchanges is that there's an issue of trust. And in fact, a lot of the time is spent with the attorneys building a distributed rights agreement to examine each other's data and make sure that the patients are on board with that. And that requires a lot of stakeholder agreements that are hard to come by. Once you have it, it works pretty well. There's always been a problem with sustainability. I just reviewed a book on interoperability, just not a lot to say about sustainability yet, what works and what's required. And that we know that health information are expensive. It requires a lot of coordination on IT, a lot of 24/7 monitoring, pretty challenging stuff. We believe that the focus on health information exchange, pulling together the distributed data, is the wrong approach. And that what we're trying to do is to repeat what goes on in the paper world. So a patient comes to see a clinician with his or her electronic health record. And right now with HIE, the idea is you go to the index and say, where are the records stored? You go out to each of those stores and you pull it back, you assemble it, you bring it back to the clinician who then sees the patient and puts the data back in the HR and the cycle goes through. The problems are that it's real-time record reconciliation. You get multiple records coming in at the same time, and you have to avoid overwhelming the clinician with too many duplicate data points, and that's hard to do. It also works best with a patient identifier nationally, of course, which we don't have. There's always the challenge that you're going to miss data, and you won't collect the full group of data. You also have a problem with the data coming from the electronic health records being assembled and then moved on to the provider, so for each data element, it's being transmitted twice, which means there's more of a security risk. Searching for research is more difficult because you have a distributed model, and that so far, we haven't found a broadly applicable way to make this sustainable. Now, this was a simulation paper where they put in a failure rate of being able to collect data from a node. A node would be an electronic health record of an office or a hospital, that sort of thing. And they set that at various levels, but for this chart, it's at failing 5 out of 10,000. That's a 99.95% success rate. Most would say that's pretty good for retrieving it. Then they looked at, well, how many times would a patient be seen in a year, and then how many providers is typical for patients to see in a given year, and as they get older, of course, that number can go 7, 10, and above. So what they showed was in simulation that you're going to have a lot more failures when you have a distributed model than when you have a centralized model where all the data are in one place. Now, the next case to me, well, why don't we just work where there's not all the data? Well, Bill Yasnoff, who founded the Health Record Bank, proposed and wrote about it that really, with electronic health records, just having only half the medication list probably doesn't make it worthwhile in order to take the trouble to health information exchange. You have to be reasonably assured that you have most of the data before those data and the effort to get to it becomes worthwhile. Again, an argument for putting all the data in one place. So that one of the challenges of many in health information exchanges is that if a patient's going to record that they have concerns about their privacy or they have requests for it, they're going to have to register that each organization across the country that has their record. And then there's a chance that they forgot one or that they have to update it, they have to go back and update them all because this is being pulled from each of those sources at the time that the patient's seen at their next provider. The challenge with annotating data or correcting data, that's difficult when you have a distributed model. So they can get back to OHSU and correct problems that they see on the OHSU MyChart or equivalent, but it's hard doing that across the country. And then you don't propagate the corrections, although the next time they pull from you, your record will send the correct record to that clinician across the state or across the country. Right now, mostly, participation in health information exchange is voluntary. And it's troublesome. Doctors have to pay interface cost, and these are reasons why you don't get full participation. Some places around the country have, but it's not widespread. So I'm just going to review graphically some of the things that we know about health information exchange currently. And this is, the following slides are about a review done and turned in March of 2016 about the state health information exchanges. Now, of course, there are private health information exchanges whose data may only be partially represented on this chart. But the idea here is that this is turned in 2016. Directed exchange, you can see that most states have directed exchange. That means direct trust. That means like a secure email where you have a clinician's secure address and you send a note as needed or when requested. So most states have that. Interestingly, not Idaho. But then when we look at query-based exchange, so the eHealth Exchange or Sequoia or Carry Quality or Commonwealth, then it's a little different. Not so many places do that, and you see Oregon doesn't have a widespread query-based exchange except what we have with Epic. Now this is looking at acute care hospitals participating in health information exchange. So according to the American Hospital Association, there are 5,400 acute care hospitals in the United States doing about 37 million hospitalizations. And you can see the number of hospitals doing some kind of health information exchange has come up dramatically since these programs are put in place starting in 2011. But you still see that only about 2,100 hospitals out of 5,400 through 2013 were participating in health information exchange, and most of that was query. And I'll bet you a lot of that is Epic, doing query to other Epic facilities. So the dark blue is directed exchange, the light blue is query. Now when we go to ambulatory facilities, the situation reverses. It's still dramatically increasing, good for that. 230,000 physician offices, 15,000 urgent care centers, 925 million patient visits a year ambulatory. And you see directed in the case of physician office way outweighs query. And it's nice to see that going up, but we still only have 30,000 offices out of 245,000 sites participating. So we're still a long way away from having the sort of coverage we need. And again, the details here aren't important. The dark blue represents 80 to 100%, and we're talking about hospitals exchanging clinical care summaries. Here's 2011, here's 2014. Well, look at that. Look who's at the top of the heap for exchanging clinical care summaries, Washington and Oregon. And kudos to us for getting that done. We're doing a good job with that. I attribute a lot of that to the concordance around Epic, but it's still a good job by our states and our clinicians to get that done. Now, this is part of that same report looking at how do you evaluate cumulatively health information exchange. And what they've chosen to do is say it can be represented by 7 different facilities. Hospitals exchanging clinical care summaries with ambulatory providers. And so, the dark blue was what was the case in 2010, and the light gray is 2014. So you can see a dramatic improvement that 66% of hospitals now exchange clinical care summaries with ambulatory providers. Not all ambulatory providers, it's just that they do it. And then the next one is exchanging clinical care summaries with other hospitals, again about 60%. Not bad. I'm choosing not to focus on lab results, both showing results and viewing results, ambulatory and ordering lab orders and viewing results. That's kind of old style here for Oregon. We did that a long time ago mostly. And physicians prescribing, e-prescribing EHR. I think that the clinical summaries is really what we're talking about. That has the core part of the data that are crucial for informing care, both real-time and in analysis. Now, this chart is about the dark blue is here is the hospitals who use health information exchange and those that use meaningful use certified electronic health records. So you see 95% of hospitals use meaningful use certified EHRs. 76% of hospitals engage in health information exchange. Here's the same thing for physician offices. 78% are using certified electronic health records, but only 38% using health information exchange. Still not bad, 38%. But look at the number of patient visits, according to this study, number of patient visits in 2 states where health information exchange data was available at the visit. So at the unit analysis of the visit, we're way, way behind in terms of providing data for care. So we've done a good job with health information exchange, but we have a long way to go, and I would propose we're not on the right track. So we have distributed architecture that we've been talking about. The information is left in place at each provider organization. You get it when you need it. It's inefficient. It's error-prone. It doesn't scale. It's harder to protect privacy. It's impractical to search for research or application processes. In a centralized architecture, the idea is you bring it together in one place, in one account, like a bank account, and that the comprehensive records over time, as they're collected, are then available to the next provider. So health record banks, the concept's been around for a long time. The earliest one that we know about where it was written about it was Peter Solovitz from MIT talking about the guardian angel. It has a long paper talking about the value that health record banks or the equivalent can bring to the process of care. Jonathan Gold, Marion Ball wrote a paper in 2007 for the IBM Systems Journal. Marion Ball has been a big advocate of this for a long time. It's a secure repository of health records. The patient or consumer decides who gets to look at their record and for how long, and is aware of everybody who does look at their record. I think the idea, the metaphor of a bank makes sense. The idea of most of us don't keep all our money on our person or in our house. We trust somebody like a bank, which are mostly trustable, notwithstanding the recent problems at Wells Fargo. But that's just leadership, and you still add 100,000 employees who are doing a great job. I'd say banks are generally trustable. And that the idea is you collect deposits, like your financial deposits, put them in a place, and then you direct how they spend. You don't just go to Wells Fargo and say, well, just buy whatever you think I need. You say, I want you to send that to Amazon, that to OHSU, that to the ballet, whatever it is. We're doing the same thing with your data. Now, HIPAA is clear, although I would say most providers don't know that. Let's read what it says about the individual. Where an individual requests an electronic copy of protected health information that a covered entity maintains electronically, which is pretty common now, of course, the covered entity must provide the individual with access to the information in the requested electronic form and format if it is readily producible in that form and format. In terms of a designated trustee, HIPAA goes on to say, an individual also has a right to direct the covered entity to transmit the protected health information about the individual directly to another person or entity designated by the individual. Pretty clear that that's the sort of thing they're talking about. 21st Century Cures, passed December 2016, also confirms their intention of a single longitudinal record. Section 4006 of this 996-page bill says, the Secretary shall use existing authorities to encourage partnerships between health information exchange organizations and networks and healthcare providers, health plans, and other appropriate entities with the goal of offering patients access to their electronic health information in a single longitudinal format that is easy to understand, secure, and may be updated automatically. They go on, the Secretary, that means the Secretary of Health and Human Services, in consultation with the national coordinator, shall promote policies that ensure that a patient's electronic health information is accessible to that patient and the patient's designees in a manner that facilitates communication with the patient's healthcare providers and other individuals, including researchers, consistent with such patient's consent. So I think the intent of both laws is clear, although I would say that most individual providers are unaware of how purposeful this is and what demands, if a patient walked in, could put on the practice. These are our principles of our alliance. Each patient's records should be functionally stored in one place, but not all records in the same place. I'll come back to that. Each patient should control access to his or her own medical records. Medical records should be stored under patient control by a trusted organization. There was an article in the Wall Street Journal a couple weeks ago that talked about patients storing all their records on their mobile phone as if they could go around and collect it. Maybe that'll come about someday, but it puts the onus on individuals. We think with a health record bank, you don't personally have to ferry checks among payment sources. We think that you're going to get a trusted organization to collect your data too. So I think it was a little misguided in the Wall Street Journal, but we'll get back to that. So with the centralized model, the clinician looks up the patient's records if it's, to get the update. In one transmission, the health record sends back a complete summary of the patient's. So far, the patient has the encounter with the clinician, and the clinician's EHR is updated, and the health bank is updated. Pretty simple. And that the patient can control it, and by the patient having all the data in one place, it makes it possible that the patient could purchase an application that would run against their data and say, well, am I at risk of such, and should I change my eating, and should I change my exercise, should I change my sleeping? The answer to all of those is yes. But nonetheless, the idea is based on their data, because we know that when recommendations are based on personal data, it means a lot more than just say, well, you should wear your seatbelt and wear your bicycle helmet, you should exercise more. When they say, you know, we've looked at your genetics and your family history and your prior problems, and you particularly would benefit by extra sleep or avoiding such and such or including such and such in your diet, that sort of thing. Now, we'll come back to the business model, but it has been proposed that we pay providers for making deposits in the health record bank. And again, it depends on the business model. We'll get to that again. So the things that are in favor of electronic health record banks are that most records at providers are already electronic. We couldn't say that in 2006. We've already talked about that consumers have a right to their record. We have standards such as CDA and consolidated CDA that work for filling a health record bank with appropriate data. You don't need a national patient identifier, because if I walk into my office for my physician and they say, where do you want a record sent? I just pull out a card, they scan it. I'm not talking about uploading it to the card. They scan it and they say, okay. And then I go home, just like from Home Depot. I go and buy something and I get a paper receipt if I want, and it's in my email when I get home. So instead of being in my email, it's in my health record bank. It could be that easy. Smartphones can help on that, and we'll talk about computer security on these. So again, we've talked about the patient depository. We have to be ready for immediate access for real-time care. We need to prevent the loss of all the data from an intrusion. I mean, Anthem with some 80 million records lost, we can't have that when we're talking about real healthcare data. And then we also need to make sure that these data stores allow themselves to be used for medical research if the consumer so wishes. So specifically getting into security, and then we'll get into searching. But talking about security now, we don't want to jeopardize all the patient data by a loss of a single decryption key, a loss of a given credentials, any single file that a person may have, or that the searcher gets access to all the data. So those are security requirements. And that we believe that it's been established a long time ago, this is from a study in 1976, that centralized data are more secure, and that you don't have multiple transmissions as you do with distributed data. But the challenge with centralized records is they have all the data in one place, and so one break-in can potentially get to lots of data, and we don't want that. So there's this perception that data in the cloud are not secure, and that is one of the challenges for all kinds of performance that we have in our society, but particularly for health record banks. So the idea that has been proposed, and there are other ideas, that the idea of storing each patient's record in a separate place where you still need 2 passwords, so that you don't get 2 passwords to all the database. I mean, a public-private encryption key. You don't get, that key doesn't get you access to all the records, it gets you access to one record. And the idea, and this here now, we're dealing with a different part of a financial bank, the security deposit. If you've ever stored stuff in there, you bring your key in from home and someone from the bank comes in and they both unlock it and then they leave you in the room to count your gold. But the idea here is that each patient's record would be under separate patient password and the system password. And that if you designate a clinician to take care of you and look at your record, that you would give her access to your key. She wouldn't know what your key is, but she gets her key through your key, and a list is kept. And then when you leave that position, you withdraw her access to your record, and she loses her key to your record. So that's the idea of storing it all in one place, but under individual password. So this is written up in Journal of Biomedical Informatics. He goes through it in detail. So the idea is that each patient's record is stored in a separate location, although all centrally. The challenge is that when you do searching for research, it can take a little longer, and we'll address that. So the idea that he wanted to show, that Dr. Yasnov wanted to show, is that searching isn't a big problem, and here's why. So if you have one record, and you're just looking for one record, you retrieve the record, you decrypt it, you examine it, and then you go on to the next record, and if you've done all n records, you exit, and you're done. So it'll take n iterations. But if you have 2 processors, then you do it parallel, and then the time it takes is n over 2. And then, of course, you get the idea that if you have K processors, which is a common way to do computing now, that you have N over K, and that in a cloud environment, it wouldn't be inconceivable to have 1,000 or 10,000 processors to do searches across 10 or 30 million people. So what he did there was to take a look at, again, simulated, along the x-axis, you have the number of parallel search servers going from 250 to 10,000. And these are commodity servers. And then along the z-axis, you have the population involved. And then the variable is, or the dependent variable is how long does it take to produce a search record where you're doing a search speed of 25 records per second. So you can see that with 5, even 10 million patients in there, that at 25 records per second searching, that you're still out at 30 minutes or so, which is pretty reasonable for research. Search is not for when you're getting care. There has to be immediate access. Search is when you're doing research, and you can afford to wait a little bit of time. So what we're doing is trading off the security of having a single person's record under a single password versus taking a little longer to do search. And then on this slide, he adjusts, and now what we've said is let's fix the population to 10,000 and say what is the effect of speed on the outcome. And you can see that if you can do 50 records per second, you can even do 10 million with a less than 10-minute recovery time. So the point is that this exceeds to widespread commodity search with multiple servers. So we balance the security of individual record under a single password versus the ability to search all the records using distributed processors. So I've just got a couple slides looking over the comparison of health information exchanges with health record banks. So we've already talked about health information exchanges as a many-to-many scattered distribution. Health record bank, you get it all in one place. Send it to one place, many-to-one to send it, and then one-to-one to retrieve it for that visit. With HIEs, you have many records coming in at the same time. You have to manage that and reconcile them. With Health Record Bank, it's already been reconciled. That's our job at the Health Record Bank, is to make the deposits as they come, reconcile it with the records that are already in place, and then you get one summarized record at the time of care. Now, if you have health information exchanges without a repository, you have no place for the patient's records all put together, but a Health Record Bank, the very essence of it is that all the patient's deposits are in one place. With health information exchange, we already talked about, you need a lot of trusted stakeholders to come together and make agreements with a health record bank. Once it's established and once the patient gives it the trust and once the patient goes to their provider and says, would you send me a copy, then you're beyond having to have multiple stakeholders agree on it. Health information exchanges are viewed by some as being the provider's record. Clearly with the health record bank, it's the consumer's copy of their professional health record, and they own it and they get to decide where to put it. Then you have genomic and imaging data. Again, more kinds of healthcare data. They're scattered all over, and especially with genomics, you're going to want them under your control and be able to add to it. And if you want to get one more panel to add to yours and do it in terms of even a retail process, meaning not necessarily for clinical care, you're going to want to store it with the rest of your data, because interpreting those genomics makes sense only in the sense of all the other habits and all the other history that you have. Now, when a consumer moves with a health information exchange, they may have a way to send the data, but especially if it's scattered data, they don't have a central repository. It's going to be hard for them to update, whereas moving with a health record bank is not an issue in the same way that even if your bank doesn't have a retail location in the small town that you move to, you can still do your banking with that original bank. Nothing changes. We've talked about consumers choosing apps. I'm talking about a mobile app or a home app, but probably a mobile app to run against their data. Hard to do against HIE where you don't really own the data. You don't really have the data under your management, but easy to do with a health record bank. If there's an error, you correct it in your health record bank, and then the next person that goes to look at it that you're going to see for care gets the updated copy. Easy for consumers to control access, and then again, as we get to patient-generated health data, easier to do it with your own record than to do it to all the providers that you might see. But there are problems with a centralized model. Who's the data steward? Who governs access? Who controls access to individual records? Who controls search? So Health Record Bank Alliance proposes that communities get together with a nonprofit board of consumers and of providers to say, what are the rules for managing this health record bank? You can have a private party, for-profit organization actually doing the storage, but we would propose that because these are sensitive, that the initial health record banks be managed by community groups who get together and they set the rules, and then they hire out the actual technical storage of their data. Another problem with centralized access is we have a single point of failure. So if Bank of Health, U.S. Health Record Bank, loses the internet connectivity because of a DNS attack, then you're without, and that's a problem that we have. And so we'll have to figure out ways to have copies of your data in multiple places so that one outage may not affect it so severely. And we've talked about risk of the whole data set being compromised. Okay, this is a proposed business model. A health record bank, according to these data, haven't been put together yet. But the idea is, well, what does it work through? What's it look like financially? So this is based on many spreadsheets putting together how many technical people does it take to manage the incoming data, to reconcile it, to manage the storage, that sort of thing. So at 1 million subscribers, they're figuring that their costs are $16 per person per year. Well, look at that. There's $6 to manage the storage and $10 per person a year to pay providers to create deposits. So if we take that out, we're talking at $6 per person for 1 million, $6 million, about the cost of most health information exchanges right now. Now, in terms of revenue, sponsorships, meaning that people that will pay because they believe that they can offer an application to the patient that the patients will want, and so they may sponsor the data. Applications, this would be paid for by consumers. For example, the emergency department access alert means, well, what happens if I fall off my bike, show up at the emergency department to see Andy? He doesn't know who I am, or he knows who I am, but I don't know my record. That emergency docs get automatic access to Health Record Bank, and everybody in my family and friends cohort gets an email that says, hey, Gibson showed up in the emergency department, emergency doctor there, open the record. Meaning that there's the break the glass access, they have get access to my full records, and there will be a price to pay if that's inappropriate. And meanwhile, my family knows that that doctor looked at it. Preventive care reminders are things that we believe that patients will pay for to help them manage their care. Medication reminders. Again, you can do preventive care reminders and medication reminders without your health record bank, but these are just examples of applications that could run against all of your data in one place. Research is a big deal, but I don't know what the value of our data are. But I would think that if you had 1 million people in a given area with their complete data, and half of them say, yeah, you can use my data for research in an appropriately identified or in a de-identified way, and oh, by the way, you're going to pay me for that, that it could be pretty valuable saying, well, what is the effectiveness of drugs out in the marketplace when they're being used? So this does not assume any healthcare cost savings. So if a health insurance company said this could be helpful for managing populations, that they might pay for some of the health record bank. The freemium model means that you get basic application, you get your record, no charge to you, and that you can buy up if you want some of these other applications. And then there could be advertising, or you could buy out the advertising by paying for it in the same way your Kindle is cheaper. If you take the advertising, it's $30 more if you take your Kindle without advertising. Just some ideas. And so running that business model through ultimately getting at 2.8 million consumers by month 48, break even was at 16 months, and substantial return on investment in the 3rd and 4th years. Again, these are just models based on number of people they felt would be necessary to run a health record bank for 3 million people. So it was tried in Arizona, 2010, 2011, and it failed. And I got to give credit to Bill Yasnoff. Ted Shortliff is the chair of the board of Health Record Banking Alliance and a long-term proponent of it. And he actually lives part of the year in Arizona. And they wrote up that they failed doing a health record bank in Arizona 2010. Now remember 2010, high-tech American Recovery and Reinvestment Act was just getting started. Electronic health records were not in as wide a use as they are now. Nonetheless, They started out with $400,000 capitalization. They had a community nonprofit that did the governance and set the rules, and then they paid a for-profit health record bank company to do the technical piece. They did initially billboard and radio, and then they went to Facebook and Twitter, and they got some uptake by consumers. They also went to large physician groups and did in-person marketing, and the physicians were signing up to get paid for making deposits to health record bank. Of course, in the early months and years, that's not a lot of payment, but over time, the idea that physicians at scale would get $300 per month for contributing data to a health record bank. And this is not onerous. You just say, you use your same EHR interface and you just put a new addressee in it, as you would with direct. They were also looking at, initially, a $99 fee to consumers. They did surveys, and they surveyed consumers, and consumers said, I'd pay between $100 and $150 to start this process, and that about 25 to 30% of people said that they would be willing to pay at that level for this. So again, that's well less than 75%, well less than 100%, but people are willing to pay some. They start out $99. What they turned out, they only got 10 consumers to sign up, so it failed. And one of the things in going back is physicians were reluctant to ask patients to pay for something that was going to cost them money directly. So our feeling going forward is we don't charge the patient because that's a non-starter. One of our challenges is that we don't believe that patients really care about their record until they get sick or until their family member gets sick or injured. I'm sorry? And the question was until somebody asks for it. Sure. So we don't care until someone asks for it, and then we wish that we had it. I have a friend who I went to high school with, college with. We went to different medical schools. He was an anesthesiologist. He had pneumothoraces. I had pneumothoraces. And he was in Hawaii. He had his lungs scrubbed from it, but it could always come back. He thought he was getting it on a weekend. He was thinking, I'm going to go to Kauai urgent care, and I'm going to have this complicated history about pneumothorax. So he was scrambling while he was having chest pain, scrambling to put his records together so that when he appeared at urgent care, he'd have a record. Well, again, as you point out, until you need it, until someone asks for it, you don't care about it, but then you do care about it all in a hurry. So we believe that the idea is make this so simple using existing standards that it's sort of like, where would you like a copy of today's visit sent? That you just do it automatically. It just collects there, and then when you need it, say, I've already got that covered. Doesn't cost me anything, and we're ready to go. So what policy changes do we believe are needed to make health record banks work? I counted two. Number one is you got to require clinicians to do what HIPAA and 21st Century Cures already require, which is send it. But instead of making it when the patient asks, just make it routine. Now, will that be politically feasible? Well, this is the challenge of my job and of this concept of can we convince them to put in a policy that you need to send it. It's not, it's obligated now. Now, I talked to Western Quality Health Network in Grand Junction, Colorado. And they're a health information exchange with a federated model. But he says that even though it's a federated model, which each organization maintains their own data, when you make a query, it acts like it's centralized. It's that fast. And I said, well, do you have a patient portal? And he says, we did. But then and they have, here's an example, one of the successful health information exchanges. Western Colorado, 750,000 patients, 1,100 providers, 130 offices, 26 hospitals, 70,000 queries per month to the database. So, and they have 94% participation among their providers. That's the sort of participation needed to make all this work. So I would say they've got what they need in Quality Health Network for real-time care. Research is another thing, patient control is another thing, but if we overlap health information exchanges with a repository, and a health record bank, I think there's a big overlap. But the idea is, I said, do you have a patient portal on? He says, well, we wanted that. But then the doctors screen because they get meaningful use dollars by showing that they have 5% of their patients actually using it. And if the patients are going to the HIE portal instead of the individual office portal, they lose their credit for meaningful use. So they had to turn it off. So again, that's a change that we need to make in the requirements to make sure that that works. All right, so we need to relax it in that case. But it's our contention we don't need new standards for health information. They're not perfect, but they're good enough to get going. Even if we have text blobs coming over for family history, maybe we can do natural language processing to pre-digest it for clinicians. That's another talk. We'll do that another day. But the idea is let's just get a copy of what's being collected anyway sent to the patient under their control. So we've already talked about the challenge, some of the challenge. Most consumers probably don't care about their healthcare records. There's an argument about whether boomers care more, about whether millennials care more. We can have that discussion. I would say that most clinicians don't know that the patient gets a copy, a full electronic copy. If they ask for it, they're pretty much used to putting their portal up there and saying that that's good. I think one of the headwinds we run into with the Health Record Bank is that there's been a lot invested in state health information exchanges. And for people to say, you know, we're going to augment that, that requires, I just think it's growth, but other people would perceive that as a failure, and I think that's a reason why they wouldn't go along with Health Record Bank. We'll see what the new administration, the new Congress does. I believe that some vendors believe that they are going to offer that personal health record with a woman's name to their patients, but I think that there's reasons to do it away from electronic health record vendors, but they may want to do that. I'd be fine if Epic, Cerner, Allscripts, Meditech wanted to do a consumer record, and we'd put up the characteristics and evaluate and say, does it meet our principles of what we want with the Health Record Bank? Insurance companies may feel some loss of power. On one hand, they may feel a loss of power that somebody else is collecting data, like the patient, that might be more powerful. The other point, if once we move to value-based payment, it may say, hey, if I can get all the clinical data and the payment data and we can engage the patients in their care, maybe they can become less expensive to manage and we'll do better. And maybe accountable care organizations would be interested in this. Of course, as with banking, we had 100 years to set up banking regulations, but there needs to be audit and there needs to be regulation, but that's not inconceivable that could happen. And then genomics and imaging data, those kind of costs that I had there weren't looking for storage costs where you have genomics and imaging data, especially imaging data. But I think storage costs will continue to come down. I don't see that as a big hill to get over, but it is a consideration. So who should host a health record bank? Governments? I'm not sure that most consumers are going to be happy with the government hosting that. Insurance companies, I think consumers feel a certain distrust with some parts of some insurance companies. Hospitals, I think, have competitive issues. They're not ideal. Physicians are working hard just to get the care done. I'm not sure they have the wherewithal to do this. Accountable care organizations, they could do this, especially when the value of all the data becomes clear, when they truly go at value-based care, and we're not there yet. Financial banks, I wouldn't throw that out. I think that there are banks that are doing medical banking. That's a different concept from health record banking. Medical banking is where banks using inexpensive technology manage the copay and the point of service collection and the deductible and all that. And Cerner ran a medical bank for their employees that made it very easy. The whole thing was reconciled, all the transaction taken care of, and the patient presented for care. And then community organization we've talked about, because if we could get a place like Portland or Oregon to say, just send a copy of what you're sending to each other, send it to a health record bank, Portland would be a great place to do this. So my last content slide, then we'll go to questions, is blockchain. What about blockchain? Lots of hype about blockchain. Harvard Business Review just had a write-up just a couple weeks ago in the January edition about blockchain. I think they got it right. I think that, blockchain is a distributed ledger. I mean, it's a great place to say, here's what happened, here's a transaction happened at a certain date and time. And things where we count on somebody else, like a county government, to store who bought houses, who recorded the title to a house so you don't get adverse claims on your house title. Or identities, who now we count on the state to do driver's license. But the idea with blockchain, great place to store where no one person is in charge of facts and transactions. But I would say it's not a good place to store the content of medical records. It's a good place to store that a patient was seen by a given provider on a given date and time. And then some doctor in New York says, I saw Gibson in New York when he was visiting, in April 29th, and then April 30th I flew out, and for some reason I had to see Andy at the emergency department having a bad year on April 30th, and that Andy's emergency department records it in Portland, the other emergency department recorded it in New York. Ultimately, the blockchain nodes are brought up to speed, and then the next person on Monday, May 1st would see exactly what order was, and they'd know where to go for my record. Not required for Health Record Bank, but I think that the idea is that blockchain is not a place to store records. It might be a pointer to your records. So that it's too expensive and too complex to store the content of the record, but it may have something to do with keeping a secure, agreed upon record, uncontrovertible record of who saw whom when. Okay, in summary, we've talked about health record banks and their data are required for safe care and population health management. We don't need any more standards to do it. HIPAA already says that for view, download, and transmit, and I went and looked at it this week to make sure it says view, download, and transmit. So a portal that doesn't transmit is not adequate to meet the letter of the law with HIPAA or 21st century cures if the patient asks for it. I think health record banks have a lot of the value of health information exchanges, but add even more in terms of patient control, the ability to upload your own data, the ability to control it, the auditing, the sense of privacy over your record. And we talked about that HRBs don't exist in that name yet in this country, although I'm trying to establish contact with health information exchanges that are run a lot in the same way. I think Rhode Island has one. I think My Health place in Ocala, Florida has that. Quality Health Network in Western Colorado may have a lot of that. And that there's also not yet a confirmed health record business model, but I think that they have a chance of being sustainable based on their value to consumers and the applications and research that will pay for Health Record Bank. So let's, we have time for some questions, and love to hear what you're thinking. Thank you. Aaron.
So since I'm sitting in for Bill today, I'll ask the first question because Bill always does. This is great, really fascinating stuff. I have a couple of questions, though, on a couple of areas that seem like they're substantial challenges. Yeah. One is that it sort of seems like it's screaming for some kind of inexpensive killer app in this space, that you bring the consumer in with the freemium model, but you're really dependent on a significant fraction of consumers being willing to pay for the updated app. And what might that be, and is there data backing up what that would be? And the second question, and maybe I just didn't see it the way what you talked about, it does seem like there's some complexity with a lot of health providers having arrangements with the health record bank in order to, you know, be assured of the HIPAA compliance and the financials and all that. So while it's maybe less complex than a health information exchange and all the N by N kind of things, it does seem like, you know, a health record bank of Oregon and Washington having relationships with all the health providers in Oregon and Washington seems a daunting task. So maybe you could talk a little bit more about that.
No, I think it is a daunting task. I think we're deep in the end zone now. I do believe that things are better now than they were 10 years ago. In terms of the killer app, I don't think we know what that is yet. I spoke with John Casillas on Tuesday. He established the Medical Banking Project. He promotes that all over the world, and that's medical banking, where you're handling micropayments and payments for health care. We talked about, he agrees, the challenge is finding that application that will make all this pay off. You know, I don't know the exact answer to that yet. There's a company called Dakadu that does a health score, and they take an enormous history. I started it, but it takes some time to complete, where they ask you about all your habits and everything that's happened to you. They ask you about your numbers, blood pressure, cholesterol, how much you exercise, what kind of exercise you do, your stress level, your status of your relationships. Pretty personal information. And then they give you a score between 0 and 1,000, and it changes day to day. And then, of course, for those that are competitive, I'm not in that sense, but for those that are competitive, they can see how they're doing relative to their buds, about whether their score is going up and down. And if they sleep more, do the scores go? Anyway, I'm not saying that's a killer app, but it's intriguing because it's based about me and what happened to me and the fact, what did I do in the past and what do I appear to be at risk at? I'd also say as those genomic markers come in one by one over time, that we'll find out things. I mean, all these things that you thought, like, why can some people smell in their urine that they eat asparagus than other people? Well, I don't know exactly what number, but they found the gene for that. Or why is it that the Inuit can eat so much fat? And I mean, there's several genes for that. I mean, all these things that why can my wife hates some spices that her whole family hates. What's the one in Mexican food? Starts with a C. Cilantro. She hates cilantro. For me, I don't really taste it that much. But her whole family, brothers, sisters, all of them hate cilantro. I'm sure there's a gene for that. Now, cilantro is insignificant. But as the genomics come in and combine with our habits and our current functioning, I think that will be valuable. Is it a killer app? The market will have to tell. And I don't know the answer to that. In terms of the complexity about building it, yeah, it's complex. But it's not like we have to start over with the standards. We just, it's already in the law that it's required. I think that we need to get a demonstration site up. And the idea, ultimately, would be we might start with a community, but I think ultimately you might look to a national organization. Like the Visa did with credit card payments, is that, yeah, you're part of the Visa network and you just send it there. We'll ferret it out, not ferret, we'll move your data out to the particular bank that's yours, but you just upload, when you do your visit, in addition to paying for it, you also just upload your record to the health bank that you have an account with. And you go online and you check it and see that it's doing well. Agreed, it's a big deal. And that's part of my job, is to figure out, create awareness, look at what we need to do policy-wise and on the Hill, and say, how are we going to bring this about? So, no, it's complex, but it's not like we have to make up a whole lot of new stuff. Go ahead.
So, thanks very much. And I first want to just say that things like this, like health record banks, I think are going to be incredibly important. But as you mentioned, there's a lot of difficulties with it. A couple that I wanted to ask you about is, one is, why, for example, do you think that it should be a privatized situation? And, why should we, or why do you think that consumers are more likely to trust a private organization or a private company to hold all of this data more so than they would trust, for example, a local or federal government? Two, I wanted to highlight one possibility in terms of, like, you're bringing up killer apps or reasons that consumers would do this, because it seems like a big hurdle is how do you get people to actually be interested in this whole thing to begin with. And that's, maybe it should be monetized for the consumers instead of being monetized for the company that is doing all of this, in the sense that consumers already, we give up all of our health data, we give up all this information, and companies like insurance companies and other corporations actually market our information out as, advertisements or other health indices or whatever. This kind of a project would definitely allow consumers to potentially take control of that.
Right.
And then the last thing that I just want to mention really quick is health providers already have access. So what would prevent health providers from doing an end run on this process? Essentially, because HIPAA does give them the right to access whatever information they need about their patients that involves direct care. So there's nothing that would force them to go to these things in order to access the information.
Taking your third question first, they'd go there because over time it would be more complete and they could go to one place and get it all. So that's why they would do it. But no, they get it wherever they would. I expect these HIEs will continue, especially the vendor-based HIEs will continue. The second one, in terms of monetizing it, absolutely. We believe that the monetization data will be very valuable, and I just don't know what the dollar amount of that is. But no, the consumer would have the right to make that decision. So different from where your data are taken out and you're not involved, this would have to be expressly saying, you get to choose, here's the value equation, here's the data they're going to use, and here's how much you get paid for it. So no, we think monetization is a big deal. It won't capitalize it to begin with because of the network effect. but over the long term, monetization is important. And the next one, for the next iteration of this talk, I will research the surveys on whom consumers trust. And I just proffered that they're more likely to trust a trusted private organization than government, but I'm just proffering that now based on my experience, but I don't have the data, and I'll work that out. So how about you and then you? Sure. Yeah, it's.
So, two questions. So then the question splits in two ways. One, if you're thinking about a national kind of organization, kind of put the national aspect to it, how do you deal with the problem of individual rural areas, which may not benefit from that, because they may try to continue the growth. And then two, if you don't go that route, you go the private route, might it make more sense to have, instead of centralized, decentralized, actually have small rural areas?
We believe regions and communities are the best. Absolutely. That's the place. Care is mostly regional. This idea that I'm in New York and I get hurt or something, that's less than 1% of that, or even less than that. So no, we totally agree. It's community-based, it's regional-based, and that's where we would start. That's the place to show it. In the long run, it could be national, but no, we agree it starts with the community, and that's where we build the critical mass. Rural, yeah, I mean, you could see that Eastern Oregon, with a few hospitals over there and the multiple providers, they could still benefit. But you're right, urban areas may benefit the most from that. But it's a model that, I mean, we look at EDIE, Emergency Department Information Exchange, and pre-manage, and how that's taken off. And all the hospitals in Washington, Oregon do that. I mean, you can see what community can do. And is it the city? Is it the state? Is it two states getting together? I don't know the answer to that. So, okay. So does that mean we can start it here in Portland? One more question I think we have time for. Thank you.
But if someone changes their address in the DMV, it automatically gets updated everywhere else. And it seems like you already have your infrastructure in place, especially with the financial banks. They already have a whole system and stuff. So why not just build upon all of those and figure out a way to merge them into one system rather than trying to put a whole new privatization of companies around it? Not only that, if you go centralized, I'm actually doing research on this. And I'm doing distributed with real-time communications system. But one of the major problems with centralized service that I don't see taken into account is what's the cost over time as energy becomes more expensive, especially with the government not supporting renewable energies. How are we going to sustain the energy cost of storing all this information, having it centralized, and making sure that it'll always stay up? Okay. If you go with a distributed system and you converted any computer into a server set that was secured, then the entire hospital OHSU literally install an application and do it, versus installing this whole new system, which would take a lot of time, energy, money, and environmental relations.
Okay. Let's stay in touch on that. In terms of putting all this together, I think it's an issue of trust, and it makes a lot of sense what you say, and the issue is, again, I need to bring myself up to speed on what consumer sentiment is on this, but I think it's an issue of trust, whether we could put all those data parts together. Right. Agreed. That's a challenge. If they'll do it if their clinician, physician advises them to. I mean, it goes way up. Now, maybe that's weak.
You start going that way, you start going to political level.
Yeah, thank you very much for your attention. Thanks for the ideas.